Good morning, everybody. Assalamu alaikum. Thank you very much for inviting me to speak about lupus. Actually, the title is simply lupus. I just made it up. So what I did is that I'm going to count my 18 minutes so that it gives me 18 minutes, 2 minutes remaining, and no one need to cut me because I get nervous when someone cuts me. So basically, today we're gonna go through a journey about systemic lupus erythematosus, or I'll abbreviate it as SLE. I'm sure most of you, almost all of you probably know what lupus means, but it's nice to have a refresher. And that's why we're using this platform and the annual American Society of Internal Medicine to remind us about lupus. So I'm going to talk about lupus in general, and then a burden of disease, and then the data from the UAE, because this is crucial. We don't need to copy data from the West because the Western patients are somehow a bit different. We need to know our data and the management and future direction. Bismillah. So SLE, or systemic lupus erythematosus, is a chronic autoimmune disease that disproportionately affects women of childbearing age. We all know that. I've seen it in our clinics. It affects more women. Ratio is approximately 9:1 on average. And the majority of patients with SLE are diagnosed between 15 and 44 years. The estimates of worldwide SLE is the incidence is 0.3 to 31.5 cases per 100,000 individuals per year. And the prevalence is 3.2 to 517.5 cases per 100,000 individuals. So SLE presents with diverse and non-specific manifestations ranging from mild to severe, life-threatening. And that's the disease with a 1,000 face. We keep telling our patients that. 74% develop moderate to severe disease, and that ranges from extensive skin rashes, arthritis, myocarditis, severe joint pain, fatigue, very common in lupus, renal disorder, and even death. Predisposition is about 15 to 30 years, predisposed to 15 to 30 years old females. So these are some of the manifestations that you've seen, I'm sure, in books or articles. Malar rash, oral ulcers, photosensitivity rash, discoid rash, Raynaud's phenomenon, non-erosive arthritis, vasculitis, hematopathologic manifestations, cardiovascular disease, subacute cutaneous SLE, and that's seen more in dermatology office, pleuritis, renal disorder, and neuropsychiatric manifestations, and alopecia. You have a lot of these manifestations. It's a disease of 1,000 faces. For neuropsychiatric manifestations, sometimes, unfortunately, physicians are not aware of these. They just mistaken it as just meningitis or drug-induced, like steroids. When we give steroids, higher dose. But always, always, always keep in mind differential diagnosis when you see patients with lupus. For example, if they come with shortness of breath, then you think of heart, lung, maybe anemia or anxiety. If you have a patient with delirium or altered mental status, then you have to think of the common things and think about disease specific. Common things would be infections like meningitis, encephalitis, the usual bread and butter that many internists forget about, and they rheumatology, come and see this patient. Oh, come on, take alprazolam. These patients you need to calm down and then do your internal medicine. You are certified internal medicine. Do your internal medicine and then think about lupus. Do lumbar puncture. So I'm saying that because I get really frustrated when I get a call from internal medicine and they don't even do the basics. Did you do lumbar? No. So go back to the basics. Basics, please, guys, basics. And then we can say this is neuropsychiatric lupus or not. Basics. It came in my Royal College. I graduated from Canada. It was a station. I do remember vividly. It was a phone call. I was surprised. I was actually in a room alone. It's like the phone started ringing. It's like, what is this? This is a station, Oski station. Hello. And the guys called me. My name is Dr. X. I'm from the peripheral hospital. I have a lupus woman who is altered mental status. I'm going to ship her to you. And that was a conversation. And just to see whether we, as graduates from rheumatology, know the basics of internal medicine. So I started talking about lumbar puncture, blah, blah, blah. Just please remember about these things. And then what happened here? The disease heterogeneity has led to lack of gold standard for defined disease activity, delayed diagnosis by 4 to 6.5 years, higher disease activity, increased organ damage, fatigue, lower health-related quality of life, and higher mortality rates, 19.2 to 8 times higher in 16 to 24 and 25 to 39 years old patient. Complicated disease management and difficulties in conducting clinical trials. See, lupus is not straightforward sometimes. Moderate to severe SLE causes systemic inflammation of multiple organs, resulting in extensive rashes, arthritis, myocarditis, severe joint pain, and fatigue, which is debilitating. You can see from this beautiful diagram, the percentage, like 40% may have cerebral manifestations, 30% have conjunctivitis sicca, very common. 80% have hematologic abnormalities, 50% have cardiovascular disease, especially on the long run. 80% have submucocutaneous manifestations, and 90% have arthralgia, and 60% have renal disease. So SLE clinical trials are difficult to conduct due to this heterogeneity, as well as lack of patients or complexities of background medication and absence of gold standard for refining or defining disease activity. If you look at the SLE in the UAE, there was one study in the UAE showed that half of all patients with SLE that were hospitalized also had presented with lupus nephritis. Most frequently observed lupus nephritis class in one study from the UAE was ISN-RPS class 2. An epidemiological study in the UAE, another one, estimated that lupus nephritis accounted for about 2% of all end-stage renal disease. You would be surprised that some nephrologists don't even bother sending us those patients. It's really shameful. So you're here to learn the basics, remind you about the basics. Please refer lupus patients to rheumatology, period. No question asked. Because we are the ones who are specialized in the disease. We attend conferences, and many of us are involved in research. We need to capture those patients because we look at the disease comprehensively, holistic point of view. I'm not only looking at blood pressure and urine, I'm also looking at other organs to ensure that the patient is receiving the best optimal therapy so that we prevent future complications. Another study conducted in the UAE found that most patients achieved remission at 6 months post-treatment, with 56% and 37% achieving complete and partial responses. So we are not doing great. We're doing good, but we're not doing great worldwide. It's not this UAE. It's just armamentarium of medications is lacking. So that's why we need to, pharmaceutical companies need to invest more in these drugs. It's a really debilitating disease. There are hypertension, diabetes mellitus, and presence of antiphospholipid antibodies were associated with poorer outcomes in this cohort. This is a literature review of lupus nephritis from the Arabian Gulf region, published this year. It identified that lupus nephritis may manifest more severely among patients from the Arabian Gulf region than in other populations, such as Caucasian populations. A greater understanding of lupus nephritis and the treatment practices within the region, as well as the development of more specific treatment guidelines for this population, may help improve outcomes for patients with lupus nephritis in the Gulf. So the pathogenetic features contributing to SLE heterogeneity, among them is genetics, epigenetic factors, innate immunity problems, inflammatory cytokines, adaptive immunity problems, cellular damage, and environmental or endogenous triggers. This is the multifaceted pathogenesis and progression to SLE classification. You start with genetic predisposition, and then some environment and hormonal triggers, especially in women. And then you have cytokine, interferon, and autoantibody production. You reach a stage of dysregulation and of multiple immune pathways with pro-inflammatory secondary insult. And that leads to autoantibody production and then activation of B and T cells. I know this slide is horrible. I hate immunology when I was in medical school, but this is something I have to live with. Summary and key takeaways. SLE may be driven by heterogeneous pathways of immune dysregulation that eventually converge into a loosely shared clinical phenotype. SLE pathophysiology is multifaceted or multifactorial, involving cells of the innate and adaptive arms of the immune system driving organ damage. Type 1 interferon is a central driver of SLE pathophysiology, and type 1 interferon recently was found to represent a key area of ongoing research that is advancing understanding of SLE. So, diagnostic classification criteria, a very important reminder. I'm an epidemiologist, so I like to talk about this. People understand the concept of diagnostic and classification. Everybody is going to classification criteria, forgetting that the diagnostic criteria in the world of rheumatology is very rare. So these are made by expert physicians, often rheumatologists. So assuming I'm going to have a good training and professors teach me and I see millions of cases, then I become excellent at diagnosis. And you base the diagnostic criteria on your head. but we don't have that in rheumatology. We have rarely these things. So we utilize classification criteria. These are essential for the identification of relatively homogeneous populations or group of patients who have similar characteristics. And these, after I diagnose them as a gold standard, then I say, how many of you, 100 patients, fulfill this man-made, human-made classification criteria so that I can talk about my patients in the UAE, same way in Jordan, same way in Egypt or the USA. So they developed 1982 American College of Rheumatology. I will refer to it as ACR. ACR SLE classification criteria. 1997 revised ACR SLE classification criteria. 2012 SLIC criteria, and finally 2019 EULAR ACR. EULAR the European. So finally the American European became friends, and let's actually divide and conquer, and let's develop a classification criteria. So without going into details, you will see that in Google. And these are the classification criteria. 1997 ACR, they classify patients according to selective criteria to definitive diagnosis, possible diagnosis as well. A negative ANA suggests very low probability of having a disease. The next one is 2012 SLIC, or SLE, Systemic Lupus International Collaborating Clinics classification criteria, clinical and immunological. It emphasized that SLE is primarily an autoantibody disease requiring at least one immunological criterion to be present, and categorized histology-proven nephritis compatible with SLE as sufficient for classification if NA or antibody to double-strand DNA were present. So there's another one. You will see it in Dr. Google. This one, classification criteria 2019 EULAR ACR classification criteria, beautiful one. Sensitivity was about 96 to 98%, and the specificity ranged from 93 to 96%, depending on the validation and derivation group. But it's a good one, yeah. But again, we're not using this for diagnosis. Diagnosis is here. And then you decide about classification criteria, whether you want to have a new drug or epidemiological studies. So flares impact on the patient. 50% of patients with SLE experience flares within 63 days of diagnosis. And moderate to severe, the SLE was associated with more frequent flares and a shorter time to first flare. For every flare, the risk of organ damage doubles. That's an important slide. Flare is bad. SLE impact on mortality and in-organ damage. Basically, here the big picture is, as SLE progresses, flares, systemic inflammation, and steroids use are associated with accumulating irreversible organ damage. The organ damage has been associated with high mortality rates seen in SLE. You can see here the Kaplan-Meier survival probability drops significantly when patients with SLE have end organ damage. So that's our role, is to try to catch the end organ damage, and you presenting here, attending this conference, will remind you about this, and hopefully you will have a quick referral to a rheumatologist. Patients with SLE have mortality rates 2.6 times higher than the general population, unfortunately. So just make sure about that. SLE impact on quality of life and work productivity. That's a common sense. You can 50 to 90% of patients with SLE report constant fatigue. Fatigue can lead to impaired work productivity and presenteeism. Now, 89% of patients with SLE in the US cannot work full-time due to disease complications. So, big picture. I don't like to preach how to be a rheumatologist. Big picture. Outline of management. Topical and intralesional therapies like sunscreens, topical steroids, topical calcineurin inhibitors like cyclosporin, topical retinoids, topical calcipotrins, and then weird drugs, which I don't use, emiguimod, that's what I found. Intralesional steroids. The dermatologists know that more than me. Systemic therapies, that's where my area of expertise comes. Immunosuppressive drugs like corticosteroids, cyclophosphamide, the bad one, not the bad one, the big one, big gun, azathioprine, mycophenolate mofetil, methotrexate, cyclosporin. Other like antimalarials, oral retinoids, leflunomide, dapsone, other things. Gold salts, no one is using it nowadays. Biological agents, we have two, belimumab and anifrolumab. Others, we have IVIG, extracorporeal plasma photophoresis and immunoabsorption, autologous stem cell transplant, in not widely used, obviously, phototherapy and laser. Again, big picture. Here, looking at the current management, it depends if the mild and moderate and severe disease. You start off with NSAIDs in mild disease, and then you think about antimalarials, and then steroids in mild to moderate to higher dose. And then you think about non-biologic immunosuppressants like methotrexate, azathioprine, MMF, and cyclophosphamide. And finally, biologic immunosuppressants like belimumab, which is labeled like FDA, Rituximab off-label. It's in the guideline, but not in the label, but we still use it. And others, like anifrolumab is a new drug that came to the UAE actually this year. And voclosporin is a new drug, but we don't have it in the UAE. So I have no experience. Why we are here? Lupus mortality has not improved in the last 20 years, like compared to rheumatoid. So we still have unmet needs and lots of drugs to be actually having. So I'll end up with a case. Let me see. Am I good? I have 2.5 minutes. Actually, I have 4 minutes. So I'm good. So case is real case. Mrs. SH is my real patient, real world case that she suffered a lot. She had a diagnosis of lupus, 51-year-old woman, Emirati, presented with maculopapular rash, non-erosive polyarthritis affecting the hands, left shoulder, ankles, and fatigue, as many patients have. Comorbidities, she has hypertension, hyperlipidemia, type 2 diabetes, diagnosed last year, January 2022. So she came to me actually from another emirate because she was desperate, and she was a rheumatologist, and she really wants to have a second opinion. Fine. So a laboratory test showed ANA positive 1/2560 speckled pattern, leukopenia, lymphopenia, neutropenia, double-strand DNA was positive 191.5, low C3. And this is so the diagnosis started in November 2015, mild SLE, and over time she evolved to have more and more fatigue and arthritis. And she was tried on hydroxychloroquine, but unfortunately she had allergic reaction, azathioprine, and unfortunately she was found to have some cytopenias and elevated liver enzymes. At that time, I thought that I will increase I thought the liver enzyme abnormalities because of the Imuran. Then I reduced it, same problem, and then I increased it because my differential diagnosis was lupus hepatitis, and didn't do anything. So I stopped it. We gave her MMF in August 2022 until this time. We gave a biologic belimumab April 2021 until January 2023 because she was adamant that the belimumab has caused the liver enzymes. We kept her on the steroids for many years, actually, from 2016 until the present time. So we switched the IV belimumab into subcut, same problem. We continued her on MMF 1 gram BID and prednisolone. So what we did is that we brought a new drug called what do you call this? Anifrolumab, the interferon changer. So in January 2023, the joint count, swollen joints were 7, tender joints were 3. And then we gave her the first dose of anifrolumab. She's the first patient in the Middle East to receive it into one. So, and then she immediately stopped the steroids after a month. Like, please don't do this. You've been on it for years. You know, as internist, that there is a chance for adrenal insufficiency. I'm stopping it. And she was happy. And I was worried that she will have dizziness, hypotension, usual. March, okay, I have 2 minutes. 2 minutes, I'll finish, inshallah. So in March 2023, joint count, swollen joints is 0, tender joints still had some tender, but she said, I'm not taking the steroids. In April 2023, the joint count was good. Swollen joints still 0, and tender joints here and there, mild. She said, I'm not taking anything for it. So that's good news. And then in January 2023, there is a HAQ, Health Assessment Questionnaire, disability score that I do in my clinic. I'm a very obsessive guy. So it was 0.75, indicating mild to moderate disability. It went down to 0 in April. And then the pain score, 7 out of 10, went down to 3 out of 10. And then in September, last month, 0 out of 10. Yay, I did something. So, and then January, this was the test result. She had normalized white cells, lymphocytes, neutrophils, and double-strand DNA went down a little bit, and she had normal C3, C4 off steroids. And in September, same result. It's good. Our first patient, actually, in the Middle East. So February, there are other indices. We call them SLIC index. It was 2, and then it was 2, which means she's stable, no damage to other end organ damage. And then there's something called SLE-Day 6. SLE-Day is disease activity score. The higher, the bad. The worse, the 6, and then become 2, and then become 2. So it's going down nicely. So we have our first local experience with this drug, and then the future. So we're having abstract in the American College of Rheumatology next month, inshallah. Demographic and clinical characteristics of patients with lupus nephritis, a multi-center study from the Gulf region. Finally, we have something common in the Gulf. And then Gulf consensus recommendation that I am leading the management of lupus. This time I brought as a convener or PI, I brought a rheumatologist and a dermatologist and other multidisciplinary, so we can have a combined thought and consensus.